My name is Haris Ali. I live in San Dimas, California. I'm an associate professor in Department of Hematology and Stem Cell Transplantation in City of Hope. And my interest is myeloproliferative neoplasm and stem cell transplant. In my spare time, I like to spend time with the family. A couple of my hobbies are hiking and mountain biking. On my days that I don't have clinic, I'm usually working on my research project in myeloproliferative neoplasms, chronic leukemias, as well as transplant outcomes for patients who are undergoing transplant for myelofibrosis. We know what are the major complications in transplant, like graft versus host disease, infection, organ toxicity. The focus of my research is actually trying to reduce those complications. Hi, Carol, how are you? When I talk to patient about stem cell transplant, I explain to the patient that the blood cancer they may have and how it can limit their survivability. Any pain afterwards? And whenever the benefits of the transplant outweighs the risk and outweigh the survivability of their condition, that's when we offer transplant to the patient. If I see a patient who is in need of transplant, usually I start off asking them what family members they have because typically we can find a donor within the family. I'm also part of the donor selection committee where through the help of NMDP we can find a donor anywhere in the world. Typically patient will ask who is the donor, where the donor will come from. Usually I try to explain to them that we will try to find the best possible match for the patient, and I try to present the data of in that circumstance what's available and what's the success of the transplant. Thankfully, I mean, for myelofibrosis it works really well. So we have our own internal data that we have published, so I share that with the patient so they know what to expect. After the stem cell transplant, patient is really looking forward for their blood counts to recover. That is the first sign of hope that the transplant is going well. Thankfully, we are living in time actually when we have a lot of treatment options. So that makes my job actually easier. And being at the big research center, we actually focus on these areas of unmet need. For example, for patients that have a bad result or may have a relapse condition, where we can offer them more options, hopefully, so they do continue to do well and live longer. I think we have come a long way. When I started treating patients about 15 years ago, transplant was quite maybe toxic at that time, and we were offering it to more of a younger patients. But now we are offering transplant even to older patients in mid-70s, high 70s if they are otherwise eligible. And novel treatments are improving the outcome of patients even going into transplant, so it can help patients to be in a better shape. Hopefully, some of these treatments could potentially be curative that patient may not need transplant in the future. Kel, good to see you. So I'll see you back in 2 weeks. With the new immune therapies coming, new methods of transplant, new combinations, new approaches, new mechanisms that are being discovered and targeted, I think the future looks good, and I think we will continue to see improvement in the outcomes of the patient with MPN.